Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at esophageal carcinoma, so if you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment, and share the link to the page so that more people can subscribe to the channel and enjoy most of this content. For the returning subscribers, thank you for returning back, and thank you for continuing to show your support. So grab your piece of paper, grab your pen, and so when we're going to be talking about esophageal carcinoma, you really need to understand that this is one of the most important causes of dysphagia because it is indeed a malignancy. So esophageal neoplasms are almost always malignant, and benign tumors of the esophagus are going to be accounting for fewer than 1% of the cases, and usually they are either leiomyomas, which are benign tumors of smooth muscle, or congenital cysts. And the only important benign tumor of the lower esophagus is, of course, the leiomyoma, which has a predilection for the lower esophagus. The majority of these benign tumors are going to be small, asymptomatic, but the larger ones can actually project into the lumen of the esophagus and lead to dysphagia, which is, of course, difficulty in swallowing. Symptomatic benign esophageal neoplasms are often treated by local resection or enucleation, and you also need to take note that esophageal carcinoma is the sixth most common cause of cancer in the world, accounting for 7% of all malignancies. Now, before I go into details of esophageal carcinoma, I want to give you a background or paradigm of tumors, because I know this is a subject that most students don't like to focus on, and it confuses most students. So let me pause a bit here. So if we look at every organ in the body, every organ is going to be having a functional tissue that is referred to as the parenchyma, and stroma, which is, of course, the connective tissue or the supporting tissue. The parenchyma may have a covering epithelium. It may also have some underlying structures. And based from these structures, tumors may arise. So a tumor may arise from different organs. If it arises intrinsically in that organ, or the tumor is first seen in that organ, or it arises from that organ first, you refer to that as a primary tumor. If the tumor has arisen in another organ and spread to that organ, you refer to that tumor where that organ where it has spread, you refer to that as secondary tumors. So primary tumors could either be benign or they could be malignant. Benign tumors are not going to be spreading via metastasis. Most of them are not so dangerous unless if they are found in a specific location or compressing on a specific important structures. Then on the other hand, malignant tumors often tend to be dangerous or fatal. So they have the propensity to spread via three main ways. They can spread via the bloodstream, which you call that as a hematogenous spread. They can spread via the lymphatic system, you call that as lymphatic spread. They could also spread across cavities, you call that as a transcoelomic type of spread. So this spread could actually be locally within the organ, or it could spread to other distant organs. Now, whenever you're now naming these tumors, whether benign or malignant, it largely depends on the tissues where these tumors are going to be arising from. A malignant tumor that's going to be arising from the covering epithelium is going to be referred to as a carcinoma. A malignant tumor that's going to be arising from glands that are present in these epithelial covering, you refer to that as an adenoma if it's a benign tumor, or an adenocarcinoma if it is a malignant tumor. Then tumors that are going to be arising from connective tissue are often referred to as sarcomas. So the two main important tumors that I want you to keep in mind about malignancy are those that are going to be arising from epithelial tissue, which you refer to as carcinomas, and those that are going to be arising from the connective tissue that are referred to as sarcomas. So we're talking about esophageal carcinoma. So a background about the esophagus is, remember that this is a tube that's going to be connecting the oral pharynx down to the stomach. Now the esophagus is going to be divided into three portions: an upper third, a middle third, and a lower third. And each of these has different muscles in the walls. The upper third is predominantly going to be containing of skeletal muscle. The middle third is going to be containing of a mixture of both skeletal muscle and smooth muscle. The lower third is going to be consisting of mainly smooth muscle. And in addition to this, the covering epithelium that is present in the esophagus is going to be your stratified, non-ciliated squamous epithelium without any goblet cells, because there is food that's passing in the esophagus, and to prevent the abrasion or to have this protective mechanism, you are going to be having this type of epithelium. And remember that the walls of the esophagus are not going to be covered by a serosa, so it means that if there is a tumor in the esophagus, it tends to spread to the adjacent structures very, very quickly. So having the background in mind, let's now get back to talking about esophageal carcinoma. Remember that this is one of the most common malignant esophageal neoplasms that's going to be seen worldwide, and there are two types of histological variants that you can get of the tumor. So it can arise from the epithelial covering, so it can be a squamous cell carcinoma of the esophagus. And remember, the esophagus also has some glands, so it can be an adenocarcinoma. And adenocarcinomas are usually thought of in the background of Barrett's esophagus. Now, I'll take you back a step when we talk about Barrett's esophagus. So you can have a patient that has long-standing gastroesophageal reflux disease, where for some reason there is acid that is refluxing back into the esophagus. Now, this acid that is refluxing back into the esophagus is going to be causing change in the lower esophagus, and so this change is going to be referred to as metaplasia. So the stem cells are going to be reprogrammed such that instead of them differentiating into forming the stratified squamous epithelium, you're going to be forming a glandular type of columnar epithelium, a simple columnar epithelium with glands, mucus glands, in order for you to produce the mucus to protect the esophagus from the acid. Now, in the process of you changing this epithelium from stratified squamous to simple squamous epithelium and the exposure to the acid, you can predispose this individual to progressing and developing adenocarcinoma. So adenocarcinomas are going to be in the background of a condition that's known as Barrett's esophagus, something that I've just from explaining. So other tumors of the esophagus that are less common include leiomyomas, they include melanomas, carcinoid tumors, even lymphomas. And most cases of the adenocarcinomas are going to be arising from the distal third, and 80% of them are going to be at the gastroesophageal junction, because that makes sense. That's where the metaplasia is taking place. You wouldn't expect an adenocarcinoma to be present in the upper third. You wouldn't expect it to be present in the middle third, but of course in the lower third, because this is where the metaplasia is going to be taking place. Now, the percentage of esophageal carcinomas is the majority. The bulk majority of the cancers, especially the squamous variants, are going to be found in the middle third of the esophagus. Remember, I say that the esophagus can be divided into three halves: an upper third, a middle third, and a lower third. So the middle third is going to be accounting for 50%. The lower third is going to be 33%. So it means the lower 2/3 of the esophagus are going to have more cancers in them as compared to the upper third, which only has 17%. And most cancers are going to metastasize to the liver, they're going to metastasize to the lungs, and they're going to metastasize to the bones. And about 35% of patients with distant metastasis are actually seen at the time of diagnosis. And early diagnosis, most of the times, is often incidental and only discovered when you are screening this patient or maybe investigating this patient for other things. So the prognosis is often poor, with an overall survival rate of only 5% in 5 years. And of course, in places where they have high concentrates of nitrosamine content in their soil, the prevalence of esophageal cancer is almost 1% in adults. And when we look at the epidemiology of the condition, esophageal carcinoma is actually much more common in men, 5 times more common in men, and more common in white individuals between the age of 50 to 70. The reason being that esophageal carcinoma is also associated with certain behaviors. We shall talk about certain risk factors that predispose to esophageal carcinoma. So these are the risk factors. You can have environmental risk factors: tobacco smoking. For example, it's a much more common trend in men, but now we are seeing more women even smoking tobacco as much as men. You also have alcohol intake, food additives such as nitrates in smoked and pickled meats. You also have diet deficiencies in vitamin A, vitamin C, and riboflavin. You also have mycotoxins. You can have some esophageal disorders. Now, there are esophageal disorders that are going to predispose you to development of squamous cell carcinoma. There are esophageal disorders that are going to predispose you to the development of adenocarcinoma. So with squamous cell carcinoma, achalasia, which is failure of relaxation of the lower esophageal sphincter, is going to predispose you to squamous cell carcinoma. Plummer-Vinson syndrome is a condition where you have dysphagia, esophageal webs, as well as iron deficiency anemia. You may also have esophageal webs occurring on their own, predisposing an individual to squamous cell carcinoma. Strictures associated with ingestion of lye, as well as human papilloma virus infections. You can also have chronic esophagitis. So the hallmark here is chronic irritation. The chronic irritation from any of these inciting agents can predispose to the development of squamous cell carcinoma. And then on the other hand, with adenocarcinoma, it's often in the background of gastroesophageal reflux disease and Barrett's esophagus that I've already explained. You also have a history of radiotherapy to the mediastinum, tylenosis, even palmoplantar keratoderma, which is an inherited disease where there's thickening of the skin of the palm as well as the skin of the soles of the feet. And then you should note that certain vitamins such as vitamin A, vitamin B12, vitamin C, vitamin E, and even riboflavin, and some trace elements such as iron, zinc, selenium, and molybdenum, those are going to be protective against esophageal carcinoma. So now let's jump into the pathogenesis of the condition. So remember that what is inciting this is that there is some mucosal insult, there is some mucosal irritation. So out of all the risk factors, all the implicated causes that we think may cause esophageal carcinoma, the hallmark is that there's going to be a mucosal insult. That's often going to be leading to a common pathway. It could be that this individual is ingesting extremely hot liquids, like for example, in patients that come from Asia, because Oriental countries are so big on tea. So esophageal carcinomas are very common in those areas. Then you could also have esophageal burns from acids or bases that are ingested, radiation-induced esophagitis, even reflux esophagitis have all been implicated in the etiology of esophageal carcinoma. You also have other things such as alcohol, smoking, nitrosamines, malnutrition, and vitamin deficiencies that also play a role. We already talked about Barrett's esophagus, which is, of course, converting the normal squamous epithelium into a columnar epithelium with goblet cells. And this is, of course, due to the injury from the acid reflux. And when we see these lesions in Barrett's esophagus, we can actually consider them as pre-malignant, because if the inciting agent, if the problem that's underlying is not addressed, this may progress into developing esophageal adenocarcinoma. And about 10% of patients with Barrett's esophagus are often going to develop adenocarcinoma, and in patients with achalasia, 5% of them are going to develop squamous cell carcinoma of the esophagus, because you have this food that keeps remaining inside the esophagus. It's not passing to the stomach, so it's going to be leading to this irritation that's going to be there, this perpetual inflammation, and eventually this is going to be leading to a progression to esophageal squamous cell carcinoma. And take note that there is no serosal layer covering the esophagus, so it means that the disease often locally advances, and metastasis is very early on presentation. So it means that esophageal tumors are going to be leading to a very poor prognosis and a very poor survival rate. Then the most common variant of the condition is the squamous cell carcinoma, which is the most common histological type. Then adenosine carcinoma is common in the lower esophageal area as well as the gastroesophageal junction, and it's very common in the west area. And macroscopically, the disease is going to be presenting in three ways. It can present as stenosis or narrowing of the esophagus. It may present as a polypoid mass, which can be fungating or even protruding into the lumen. It can also be presenting as an ulcerative lesion. And then, of course, the growth of the esophageal cancer, whether it's squamous cell carcinoma or adenosine carcinoma, usually occurs by intraesophageal spread or direct extension, or it could be through lymphatic or hematogenous metastasis, of which I explained when I talk about spread of malignant cancers earlier on in the video. Then with squamous cell carcinomas, they are more typical to invade adjacent structures as compared to adenosine carcinomas. And Distant metastasis is often seen in 25 to 30% of patients at the time of diagnosis. The most common sites include the liver, the lungs, the bones, which are very frequent, and of course early cancer of the esophagus confined to the mucosa. Submucosa is only detected on screening, and both types are going to be spreading to the regional lymph nodes once the muscle coat has been involved, because there is no serosa. They can spread via three ways. They can spread directly, so because of the lack of the serosa in the esophagus, this is going to be favoring local extension. So in the upper third, it's going to be spreading through the muscular layer, and it's going to be adherent to the left main bronchus, the trachea, the left recurrent laryngeal nerve. Of course, if the left recurrent laryngeal nerve is going to be involved, there's going to be some hoarseness of the voice. It may also affect the aorta or its branches, which can actually lead to a very dangerous type of hemorrhage, but this is very rare. It may also lead to perforation and also cause mediastinitis. Then if it spreads via lymphatics, it's often spreads both by lymphatic permeation as well as lymphatic embolization. So lymphatic permeation is where the cancerous cells actually invade into the walls of the lymphatics and spread into the lymphatic vessels. Then of course embolization, you have this cancerous cells seeding into the lymphatics and going to lodge or going to be implanted at certain areas. And of course it can cause satellite nodules elsewhere in the esophagus away from the main tumor. And of course above in the neck, it spreads to the supraclavicular lymph nodes. In the thorax, it's going to be spreading to the paraesophageal, the tracheobronchial lymph nodes, as well as to the subdiaphragmatic lymph nodes. In the abdomen, it spreads to the celiac lymph nodes, and it may spread to the bones, where it spreads to the liver, lungs, the brain, and the bones, which are very common sites. When it comes to the clinical features of the disease, so at the time of diagnosis, most patients may have an advanced disease because the cancer usually tends to spread, and by the time it's detected, it would have already metastasized, and these patients may not actually be candidates for the resection or for the surgery, because the tumors have to be removed. And if they have spread to distant locations, then we can offer the patients radiotherapy and chemotherapy, but it wouldn't have any significant improvement if we were to go in and remove the tumors. So the lack of the serosa and of course the rich submucosal lymphatic network means that it spreads very quickly and very early into the adjacent mediastinal structures, and of course very early into the local lymph nodes. And about 70% of the patients have mediastinal, even extrathoracic lymph node metastasis at the time of diagnosis. So this is how your classical presentation of a distal esophageal adenocarcinoma is going to be. So this is going to be in an old individual, and of course in the background of a gastroesophageal reflux disease, and there is going to be progressive dysphagia. This is very important because the dysphagia that you get from esophageal carcinoma is going to be different from a dysphagia that you're going to be getting from an achalasia. So with achalasia, the dysphagia is going to be first for liquids. With esophageal carcinoma, the dysphagia is going to be first for solids and then eventually progress to liquids. This already makes sense because there's a growth that is physically in the lumen and reducing the size. So it means that food that's supposed to be moving from the esophagus to the stomach during the process of deglutition or swallowing is going to have a hard time. So this dysphagia is not often seen unless if the obstruction of the esophageal lumen exceeds 60% of the lumen. And of course the progressive dysphagia is going to start with solids such as meat, and then you progress to soft foods and eventually liquids, and then finally in several months even saliva won't be able to be swallowed. And then of course esophageal obstruction is going to be resulting in malnutrition because food is not going to be passing to the stomach and digestion is going to be greatly impaired. There may be weight loss, there may be regurgitation of the food, so it means that they are at risk of aspiration, especially when sleeping. Then typically patients are going to feel well, so they may not have any other symptoms, but some patients may have non-specific GI symptoms. They may have mild weight loss, they may have easy fatigability, weakness that is often related to, of course, a diminished caloric intake due to these obstructive symptoms. So this weight loss and the weakness is going to be due to the calories not really passing in the GIT and not the cachexia that's going to be arising from the metastatic disease. The patients may sometimes have chest pains. There may be some pain on swallowing, which is known as abdominophagia. There may be invasion of the recurrent laryngeal nerve, which is going to be causing hoarseness of the voice, as well as a vocal cord paralysis and severe extents. You may also get features of bronchoesophageal fistulas, which are very common in carcinomas that are going to be affecting affecting the upper third of the esophagus. They are seen in about 30% of these cases. You may also have substernal, even abdominal pains, and of course patients with esophageal squamous cell carcinoma often have a history of heavy alcohol intake and tobacco use, and of course they're going to be presenting with more pronounced symptoms because they are going to be presenting at a more advanced stage of the disease. When you perform your physical examination, you may get your non-specific findings, but the patients may appear well unless if they have significant metastasis to distant organs. They may have a supraclavicular lymphadenopathy at presentation, but of course this is very rare. So in advanced disease, patients are going to be appearing cachexic. They're also going to be having supraclavicular lymphadenopathy, and they may also present to you with other signs of distant metastasis, and they may develop symptoms of local invasion such as stridor and cough if it's spreading, of course, to the respiratory airway. They may lead to aspiration pneumonias, hemoptysis, which is coughing out blood, vocal cord, even recurrent nerve palsies. Then you may have hoarseness of the voice if there is involvement of the recurrent laryngeal nerve. You may have hiccup if there is involvement of the phrenic nerve. You may have Horner's syndrome if there is involvement of the sympathetic fibers. You may have supraclavicular lymph node enlargement. Of course, distance mets to the spine may lead to spinal pain. On the diagnosis of the condition, we want to order some diagnostic investigations. So there are some imaging tests that we can order for. So we can do a barium swallow, which is of course going to be detecting 96% of the patients. So the barium swallow must actually be precede the endoscopy, and of course this is going to help in preventing inadvertent perforation of the esophagus. Then findings are going to be ranging from, of course, a small mucosal defect to an apocore lesion. I'll show you what an apocore lesion looks like on barium swallow. And of course, there is going to be complete obstruction, which may show shouldering signs, even irregular filling defects. Then you may get this irregular stricture with shouldering and moderate proximal dilatation of the esophagus. Then when you perform a flexible endoscopy and biopsy, this is of course for a definitive diagnosis. So if Barrett's esophagus alone is noted, then of course the extent of the disease can be determined and the biopsy performed to look for the dysphagia or carcinoma in situ. Then 3/4 of adenocarcinomas are going to be found in the distal esophagus. Most of the squamous cell carcinomas are found either in the middle or the lower third. And of course, cervical esophagus is a very uncommon site for the disease. Then you may also perform endoscopic ultrasound, which is used for primary tumor staging and regional lymph node status. So of course the ultrasound is going to be depicting the normal 5 layers of the esophagus and can accurately actually determine the tumor status in 85% to 90% of the patients. You may also perform a 5-needle aspiration biopsy for abnormal appearance of certain lymph nodes under your ultrasound guided biopsies. Then you may also do CT scans or PET scans, which are of course best used for evaluation of the regional as well as the distant disease. And of course CT scans may assess operability and in most cases can only give a palliative rather than curative type of surgery. Here is an example of a barium swallow. So here in this first image here, you have a contrast radiograph that's going to be showing this typical apple core. So this looks like an apple. So if you were to imagine that this is an apple and someone has taken a bite out of this apple, so this is of course your apple core lesion or your apple core appearance that's going to be affecting the lower 1/3. And then of course here in the image B, we can actually even see the ragged edges of the esophagus, which are of course going to be indicative of an esophageal carcinoma in the distal third, which is in this area over here. And then we can see that this is the stomach. So this is the cardia here, and of course this is the stomach over here. Here's another example of a barium swallows. So of course you have squamous cell carcinomas that are going to be affecting the middle third of the esophagus in this image A. Apologies for the interruption in the video. I ran through some technical difficulties. So as I was saying, image B here is going to be showing you the adenocarcinoma of the lower third of the esophagus. Then moving on to an endoscopic view, this is what you may see when you perform an endoscopy in a patient with esophageal carcinoma. Then of course some supportive investigations include a full blood count, a chest x-ray to check for aspiration pneumonia, abdominal ultrasound to actually assess the liver and the lymph node status in the abdomen, liver function test, urea electrolytes and creatinine, blood grouping and cross-matching. And you can also perform a bronchoscopy, especially in proximal proximal esophageal tumors to exclude any bronchial involvement, and this together with a vocal cord as well as phrenic nerve paralysis, involvement of mediastinal structures, especially in the aorta, as well as distant metastasis, as the presence of these features may exclude a patient from having a surgery done on them. When it comes to the TMN staging, T for tumor size, so TX when the primary tumor cannot really be assessed, T0 when there is no evidence of the primary tumor, TIS for a carcinoma in situ, T1A where it invades into the lamina propria, T1B where it invades into the submucosa, T2 it's going to be invading in the muscularis propria, T3 it invades into the adventitia, T4 it's going to be invading into the adjacent structures. When it comes to the regional lymph nodes, NX if you can't really assess the regional lymph nodes, N0 for no regional lymph node metastasis, N1 for regional lymph node metastasis, M for metastasis, MX if you cannot really assess the presence of distant metastasis, M0 when there is no distant metastasis, M1 where there is distant metastasis. So here are the different combinations that are present for each of the different stages from stage 0, stage 1, stage 2A, stage 2B, stage 3, and stage 4. Take your time to actually learn through this TMN staging and actually practice it on the wards whenever you see a patient that has an esophageal tumor and all the necessary investigations done on them. The management is going to be dependent on two things. It's going to be dependent on the stage of the disease. It's also going to be dependent on the condition of the patient. So in some patients, you may have a resectable lesion, but they may be unfit for the surgery, or they may have significant comorbid conditions. And in patients where the nutritional status is very poor, you should actually consider boosting the nutritional status by enteral nutrition before they can undertake the surgery. And then, of course, the goal of the treatment is going to be removal of the tumor and the regional lymph nodes that are affected, and of course, followed by reestablishment of the gastrointestinal tract continuity. And of course, the treatment of patients who are unfit or patients that have locally advanced disease is by chemoradiation or chemoradiotherapy. This is, of course, going to be followed by restaging of the condition. And of course, if the patient is fit for surgery, when they are downstage, they can actually go for surgery. Then in localized disease or early stage disease, surgical resection may be done, especially for symptomatic patients. And of course, you can use a right thoracic or a transhiatal approach. A gastric pull-up or colonic interposition can also be used to reconstruct the gastrointestinal tract. Esophagectomy is going to be providing a possible cure for the condition. And when you're performing your resection, your proximal extent of your resection should be 10 centimeters above the macroscopic tumor, and the distal extent should be about 5 centimeters below the distal tumor. And of course, the proximal stomach should also be removed commonly, especially in 1/3 of the cases of the tumor. And of course, if you have sufficient removal of the adjacent structure, this may be curative. You should also perform radiotherapy for prevention of perioperative morbidity and mortality, as this can shrink the tumor, but it may predispose to local complications and it may not palliate dysphagia or odynophagia. Then in preoperative or postoperative chemotherapy, we can use this to downstage the patient, especially patients with resectable bulky tumors. And there is now an inclination to most surgeons using all three modalities: surgical resection, radiotherapy, and chemotherapy. But of course, there is still some controversy. Some people say that it has improved the long-term survival of the patients. There are some surgical approaches that can be used. The most common surgical approaches are the transthoracic or thoracotomy and the transhiatal without thoracotomy, and incisions may be required in the neck, in the chest, and the abdomen. So the most common transthoracic esophagectomy is, of course, the Ivor Lewis esophagectomy, often named by the surgeon that first discovered it. And this is going to be involving the upper midline laparotomy with mobilization of the stomach. And then, of course, this is going to be followed by a right thoracotomy with esophageal resection and anastomosis that's going to be made. And of course, it's very useful for patients that have tumors that are present in the middle as well as the lower esophagus. For tumors that are present in the upper esophagus, there's a modified procedure discovered, which is going to be involving the intrathoracic esophageal mobilization and anastomosis in the right neck through a separate cervical incision. So you call this as a 3-hole technique. Then, of course, tubularization, the tubularized stomach, rather, is going to be used as the esophagus substitute in most of the cases. And other possible substitutes include the colon, even the small bowel, where you replace the esophagus with another part of the GIT. Then esophagectomy without thoracotomy is going to be termed as a transhiatal approach. So this technique is going to be using laparotomy for gastric as well as esophageal mobilization. Then you're going to follow this by left cervical incision for the anastomosis. Then of course the major benefit for this approach is avoiding the complications that are going to be arising from thoracotomy. Then with advances in medicine, esophagectomy can now be performed using laparoscopy as well as thoracoscopy techniques. And of course the cervical incision is also used. And this is going to be complex and very challenging procedure that has a very steep learning curve. And of course the early results of laparoscopic esophagectomy seem to compare favorably with open surgery, and though there isn't so much data on that's available at the moment. Then of course post-operative management, you want to give your fluid and electrolyte management, you want to cover them on antibiotics and give them proper analgesia, respiratory care, ICT care, even physiotherapy. You want to prevent DVT by elevation exercises, heparin. You want to monitor for bleeding, sepsis, any leak, even monitor the oxygen saturations. Total parenteral nutrition should be used during the initial post-operative period, as well as early jejunostomy feeding for nutrition. In advanced stage 4 disease, chemotherapy can actually promote the tumor shrinkage. Then of course palliative care for the symptoms, as the survival rate is poor regardless of whatever you do. Post-operative complications include fistula, abscesses, even respiratory complications. Other options of treatment include endoscopic laser therapy, endoscopic dilatation, and stent placement, or placement of gastrotomy, even jejunostomy. Non-operative treatment includes radiotherapy and chemotherapy. With radiotherapy, this is often going to be done by supervoltage external beam radiotherapy, and this may be curative if it's radical, or it may be palliative to relieve the dysphagia as well as the metastatic bone pain. It can also be given as an adjunct to surgical treatment, either in the form of a multimodality treatment or after esophagectomy to improve the local regional control. Contraindications to radical radiotherapy include large tumors that are greater than 9 centimeters, presence of a tracheobronchial esophageal fistula. The main disadvantage of radical radiotherapy are, of course, the development of fibrous strictures in half of the patients that are treated. In brachytherapy, which is interactive irradiation with cesium or iridium pellets loaded into an applicator and placed into the lumen of the esophagus, we can use this as another technique that can be used for palliation in cases of dysphagia. When it comes to chemotherapy, several agents can actually be used in combination with surgical modalities of treatment in esophageal carcinoma. Then you can use drugs such as 5-fluorocytosine, cisplatin, mitocin C, paclitaxel, even etoposide. So paclitaxel is going to be achieving a high response rate in metastatic esophageal cancers and can also act as a radiation sensitizer. Then most combinations are going to be having 5-fluorouracil with, of course, with or without leucovorin. Then the second most commonly used agent is, of course, cisplatin. Then palliative care is usually offered in patients with advanced disease, so this is often directed to relieve the dysphagia. Several methods can actually be used, such as recanalization, where you can perform a photocoagulation together with dilatation. You may have a photodynamic ablation using hematoporphyrin derivative, followed by irrigation with red light of a wavelength of 630 nanometers. This is, of course, going to be a combination that's going to be causing necrosis of the tumor by highly reactive oxygen species, such as oxygen with a single electron. Then endoscopic guided procedures can also be done in esophageal neoplasms. You can also have intra-tumor injection of absolute ethanol, of course, to shrink the tumor. Then, of course, you can also perform intubation, which is widely used as a palliation for dysphagia in non-operative esophageal cancers. The main disadvantage is that treatment is often going to be performed in a single session, and there's going to be dramatic restoration of swallowing. Plastic tubes can actually be placed, which are self-expanding metallic stents, and these may actually prevent excellent palliation and are relatively easy to insert. You may have several types that are available, and some patients may develop malignant tracheoesophageal fistulas, which can occur spontaneously or after the radiotherapy, and they can be sealed or covered with self-expanding metallic stents. Surgical bypass is rarely done nowadays. But of course, a gastrotomy and should not be done as a palliative procedure. Indications for palliative care include things like patients that are not fit for major surgery, patients with metastasis via the blood to adjacent organs, even to the peritoneum and the liver. The indications include relief of pain, relief of dysphagia, prevention of bleeding, as well as prevention of aspiration. Complications of esophagectomy include 5 to 10% mortality if you're one of those people who believes death is a complication, hemorrhage, respiratory infections that are often severe, septicemia, chylothorax due to injury of the thoracic duct, anastomotic leak, which is going to be thoracic leak, which is the most dangerous type of complication, hoarseness of the voice due to recurrent laryngeal nerve palsy, stricture formation in 40% of the cases, gastroesophageal reflux disease and gastric transfer, as well as conduit necrosis due to ischemia, either affecting the stomach or the colon, and then of course colonic dysmotility causing partial obstruction in colon transfer. Thank you for spending your time to listen to this review lecture video on esophageal carcinoma. If you really enjoyed the video, drop a like, drop a comment in the section below, share the page, keep on subscribing on our road to 1K subscribers. We are very, very close, so keep sharing the information. Thank you to Zambia and beyond. My name is Dr. Moses.